We have with us today from right here, we have registered nurse Corey Ranger, president of the Harm Reduction Nurses Association. He's going to be our moderator / participant for this dialogue. We've got Karen Urbanoski, Canada Research Chair in Substances, Addictions and Health Services, University of Victoria. Next to her we have Jen Bowles, University of BC Research Scientist in the Department of Medicine, BC Centre on Substance Use. And at the end we have Dr. Reka Gustafson, Island Health Chief Medical Health Officer. And I'm just going to turn it over to Corey, and they're going to have a fascinating conversation.
It's so great to be able to have the opportunity to speak with you all today. As Jody said, my name is Corey Ranger. I use he, him pronouns. I'm a registered nurse, and I'm the president of the Harm Reduction Nurses Association. I usually reside on the unceded territory of the Cowichan tribe in what is colonially referred to as Dungan, but I'm very grateful today to be on Lekwungen-speaking people's traditional territory. I think it's important that we all have an opportunity maybe at the start to reflect a little bit on what we've heard. And today's session is about evidence and services. And so let's start off this conversation with, what do we know? We actually know the drivers of the unregulated drug poisoning emergency. We know after 8 years, 10 months, and 5 days of a declared public health emergency, what is killing 16,000 British Columbians. We know what is driving this crisis, and we know that what is driving this crisis is a drug supply that is criminalized, one that is contaminated with unpredictable and unwanted adulterants, one that offers no agency of choice for people who are compelled to access this supply. And for those of you who think this is an issue only for opioids, we also know that people who use stimulants are dying because stimulants are also contaminated with fentanyl. This is a drug poisoning emergency. And we also know a lot about the services that were just discussed earlier today. In fact, there is a lot of evidence that supports all of the services that we heard about. When it comes to prescribed alternatives, there are over 93 peer-reviewed journal articles, evaluations, scoping reviews, evidence briefs that all demonstrate a potential to reduce the risk of harm and death. We've seen large-scale population studies, which some of our panelists here have been a part of, that have demonstrated a reduction in all-cause and overdose mortality risk. We have studies that show that when people access prescribed alternatives, they're actually more likely to stay on their addiction medicines like methadone, even though there are some who would like you to believe that prescribed alternatives impedes access to recovery. We know a lot about supervised consumption services and overdose prevention sites. We know that those services save lives, improve the health and well-being of people who access them, improve community health outcomes, and save the health system money. We know that access to harm reduction services like needle distribution programs significantly reduce the risk of transmitting HIV and hepatitis C. These are public goods. Less HIV and less Hep C is good for everybody in the community. And so we find ourselves at a crossroads here because policymaking is not being driven currently by evidence. In fact, what we're seeing is a significant amount of policy regression on the heels of moral panic. We're seeing harm reduction kiosks being shuttered overnight because a conservative MLA tweeted about it. We've seen the full rollback of decriminalization because some people videotaped someone smoking crack in a Tim Hortons, even though it was already illegal to do that, even under decriminalization. We've seen doctors risk their jobs to set up overdose prevention services outside of hospitals while larger institutions lag behind in their response. And so we have to ask ourselves, if it's not about the evidence, what is it? There's a concerted effort right now, and maybe for the last 2 years, to convince the people of British Columbia that they're unsafe. And the reason why they're unsafe is because of people who use drugs and the policies that supposedly enable them. This is misinformation, disinformation, and moral panic. And when we're able to tap into people's fears, when we're able to convince them that they're not safe, then we're able to create a public outrage that's strong enough that it'll actually change voting patterns. And when voting patterns change and people feel their ability to retain and get power slip, then they'll make policy changes. And so this is a moral panic. This is about power and the ability to retain power, and it's important that we name that. And I'm really excited to be passing this over to Karen Urbanoski for her thoughts. But I want to just add this comforting fact that the first step to fighting a moral panic is understanding it. Thank you.
Regretting slightly being scheduled to follow up Corey. That is not easy to do. So hi everyone, I'm really glad to be here. I'm Karen Urbanoski. I am a scientist at the University of Victoria. I am located at the Canadian Institute for Substance Use Research, which Emily spoke about earlier today. I've been working for about 2 decades in the area of substance use services research. Pull that a little bit down. And what that means is my research tends to focus broadly on what types of services are out there, less about the sort of clinical elements of what works and doesn't, but how services are fit together to create a system, what multidisciplinary collaboration looks like within services, how services with different types of goals and purposes and functions work together to create a system. I'm one of the co-leads of the provincial evaluation of prescribed safer supply. I've been doing that work since 2020, and I bring that system lens to the work that I do in that project. So anytime any new intervention of any sort is added, it's not added in a vacuum on its own. It's added into an existing system with strengths, with gaps, with challenges, with successes. And these services all work together to create a support network for folks so that they have options to choose depending on what their needs and their past and their goals are. Now, I will say, as part of the prescribed safer supply evaluation, what we've been able to do is to connect nationally with folks working in other provinces to look at the national evaluation of safer supply that's going on in Canada, and we've been able to scale down and also work locally. So we contribute to to working with Vic Safer on the evaluation and some of the publications that you saw earlier today. That's really given me a pretty broad landscape to draw from, and prior to that, the years of evidence the years of experience I have in sort of creating the evidence, reading the evidence, and engaging with it. And I think one critical point that I'd really like to make, which actually dovetails perfectly with what's already been said today, is there is a wealth of evidence that we can draw from that says there is no one intervention that is going to work for everyone. People need options, and they need them the day they decide they want them. So if you wake up in the morning and you want or you need supports of a certain kind, what's available to you that day that you can go out and access in a safe way for you, in a way that respects your culture, your gender, and so on? This is the truth. This is the truth. This is the nature of the health condition that services are there to create, is that that's what we need. And instead, I think because of years of crisis, because of a scarcity model of service provision and just fear around looking at the photos, seeing the volume of death, seeing what we're seeing on our streets today with the housing crisis that's coming to play here as well, what we see is camps forming. We see a loss of nuance in the way that we understand evidence. And so I just want to make the point that evidence in favor of one intervention it's not evidence against another intervention. Finding multiple interventions work is not contested evidence. It doesn't mean that one study was wrong. It means that people need to have options, that it means we have more tools in our toolbox. And so I'd like to return, what I'd really like to see is a return to some nuanced discussion around how the services that fit under a harm reduction umbrella, how the services that fit under a treatment umbrella actually need one another in order to function, right? And a good example of that is one that came up just that you mentioned, Corey, is that we have seen increases in OAT retention associated with hydromorphone prescribing. This is a service that is being called upon to evolve to the context of the toxic drug supply and to keep up with what the community needs. And Prescribed Safer Supply and OAT can work together in that way to see that happen. And that's just one example. There's many, many examples of the ways that the outcomes of an evidence-based service are maximally achieved when it's embedded within a system of other effective services. I'll leave it there.
So my name is Jen Bowles, and I'm a research scientist at the BCCSU at University of British Columbia, which I know was already mentioned. My thesis when I was working on my doctorate, I was working with an advisor who, this is back in like 2011, and this was in Philadelphia. I grew up in New Jersey. And I saw that my advisor was doing work on naloxone distribution, right? And harm reduction was something that I never really had to struggle with. It was a concept that was introduced to me, and it just made sense to me. But I understand that not everybody is quite there or on board, or might never really fully come around to supporting some of the work that we do. But I feel like it was something that was really pragmatic and just made sense to me. And what I liked about the opportunity to explore how naloxone was functioning within the community is that it was taking a resource that typically had to be relied upon to receive through the medical system, right? And it was giving it to people directly so that they could reverse overdoses among their network of peers, or to it could be to a complete stranger who was overdosing. And what the impact of that was, and among people who use drugs. And this was initially happening kind of in like an underground circuit, right? Like there was authorization from the government in order to do it, but the way that it was playing out within the social networks of people who use drugs in Philly is it was like, where did you find out about getting that, they called it the come back to life drug. They're like, where did you get that come back to life drug? And so people would tell them, oh, you can go over here to this harm reduction center, which was also a syringe exchange program. I say exchange specifically because it was not an access program. You had to exchange in order to get syringes. But you could get naloxone there. You could get trained in like this 5-minute quick, like this is how to recognize the signs and symptoms of an overdose. Here's how to prevent one from becoming fatal with this drug, naloxone. And I started working kind of within the fringes of harm reduction in the US as a result of this. It was a bit outside of the medicalized system and understanding what are the ways and means that people who use drugs are working together to keep one another safe, right? That having to rely upon a medicalized system that has been mentioned previously is not always trusted, and for very good reason, right? Like people sometimes walk into a hospital and are treated terribly. And so there's no impetus to feel like this is a space of healing. And so I feel really fortunate that I'm somebody who, when I moved to Vancouver, I got to be one of the evaluators of DULF, of the Drug User Liberation Front's Compassion Club. And I'm also currently evaluating Road to Recovery, which was mentioned here before. So I'm kind of seeing this spectrum of the Compassion Club approach all the way through to this like new clinical model of treatment and of recovery, and what are the different ways that both from a medicalized perspective and through communities of people who use drugs, we're trying to reduce the harms that are growing more and more complex by the day. And we hear this all of the time in research. We hear complex withdrawal. We hear about complex wounds. We hear about the complex toxic drug supply that consists of, new things that we're learning about on a daily basis. And so something I want to mention about with the Compassion Club that it really sought to do was take away some of that complexity and bring us back to a simple kind of like, here are the substances that it is that you're seeking, and see how it was going to stabilize people's lives. I'll leave it at that for now and pass it on to Reka. Thank you.
Hi, everybody. I'm Reka Gustafson. I'm the Chief Medical Health Officer for Island Health. And in that role, I'm a public health doctor, which makes me different from the addiction medicine colleagues who spoke before, who are providing care for individuals or groups of individuals. As a public health doctor, where our patients are communities, and our medicines are communication and organized activities of society. And so one of the things that we tried to do is, rather than looking at what an individual did, we look at what kind of environment do individuals and communities exist in order to make them well or less well. And so the reason I'm talking about that is because we had a lot of really great presentations about individual care and what kind of programs work for people. And complementary to that is what we as public health doctors do, which is really try to see what drives what we call dominant narrative. So what people talk about, what people think about, what they talk about and they think about drive the decisions and the policies that they make that either make us less healthy or more healthy. And one of the reasons that's important for substances is because substances exist at a societal level. They're an inherent part of our society. And I mean that in general for all psychoactive substances. It's part of the human experience. But one of the reasons that we've landed where we've landed today, when you actually look at the history of where we are, is that we actually look at substances in very, very different ways. How we look at one substance versus another is a result of history and perception, often which country tried to force which other country to use their opiates. England shall not be mentioned here. And as a result, we landed in 2016 when the emergency was declared in a situation where if you actually look at the data of how substances harm our health, the two top substances are opiates and alcohol. Yet alcohol and opiates are treated completely differently by our society. One is legal, celebrated, and in fact, we have stated goals in policy goals to increase consumption, to make it easier to buy alcohol. The other substance that's harming our society is really significantly, of course, is opiates. And that one is illegal and it's criminalized. And we create a situation where our policies, which make them illegal, makes it impossible to gather data really about who's consuming it, how much are they consuming, where are they purchasing it, what's in what people consume. And sometimes I think about these two extreme approaches to substances and think, both harm people, the difference is who makes the money. And one of the reasons that we've actually, as Dr. Hislop mentioned, we wrote a report on these substances is to try and actually start to change the public perception of what these substances are. There are no good substances, there are no bad substances, there are just substances as part of human experience, and how we as a society choose to treat them determines whether or not we maximize or minimize harm to people. There is not morally superior substance or a morally inferior substance. There is not a substance that makes you a better person if you use it and a worse person if you use it. They simply are. And one of the last things I want to share is that the last substance, and I want to compare this to, is tobacco. About 50 or 60% of the world of the Western world was using tobacco in the 50s and 60s. It killed one out of two people who used it chronically. And we as a society, through our organized efforts, decided to do something about it. We decided to have a strategy that had health at the center, and we decided to use the tools that are available to you if a substance is legal to minimize the harm of society. We used taxation, we used a ban in advertising, we used changing the actual content of the substance, using age limits to make sure that young people couldn't purchase it, and we denormalized the use of tobacco. And over 50 or 60 or 70 years, we actually changed the trajectory of the biggest substance-related killer in our society. So one of the reasons that we did put this report out is to try and challenge some of the dominant narratives, some of the moral panic, some of the substance-specific hysteria that's out there, and really bring it back to that recognition that we, through the organized activities of society, know what to do, and we are choosing not to. And which means that we have the ability to change that. We can choose to do it. We can choose, but one of the most important things in the long run is that the tools that we know that work, which is controlling what's in the substance, controlling taxation, pricing, availability, and advertising, can only happen for a substance that's legal. And as long as a substance is illegal, we are consciously forfeiting the tools that we know that work. And so that's really one of the areas of thought and evidence that we're gathering. As a public health doctor, I have the privilege to gather that data, to share that data, and I really appreciate being able to talk to you about it and join my esteemed colleagues, academic colleagues, to share that part of the evidence. And I just would like to, one last thing I'd like to say is that one of the things that comes with that privilege is a responsibility, and one of the ways that I had the ability to use that responsibility before I was the Chief Medical Health Officer here is I got to work at the BC Centre for Disease Control. And during the pandemic, you heard about deaths related to COVID every single day. And we were able to use vital statistics data to look at what was actually killing people during the pandemic. And during the pandemic, the top cause of death and top cause of potential years of life lost was overdoses. And it's one of the things that I think was really, really important to try and make sure that in our enthusiasm for pandemic control, we didn't actually cause greater harm. And I don't think we succeeded at that, but at least we had the opportunity to name it. Thank you.
Thank you so much for everybody's kind of opening remarks. I think I'd love to just kind of dovetail a little bit off of what Reka just said and talk a little bit about your example with alcohol, which is celebrated. And last year, BC Drug Checkers released a fact that stated approximately 3% of all stimulant drug samples contain fentanyl. And I think about that a lot because 3% doesn't sound like a lot, but when you think about the 225,000 British Columbians who access unregulated drugs per year, that's quite a bit. And if you could imagine going to the liquor store after this event and buying your favorite bottle of wine and you knew that there was a 3% chance that your bottle of wine contained fentanyl, we would probably see a lot of outrage. We would see a significant outcry. We would also see product recall. We would see warnings in public advertising. And we don't get that with the unregulated drug supply. And so I'm interested to know from the panel, why the disconnect? Why do we know so much about what's causing death? Why do we know so much about what potentially can help stop the deaths? And yet we're not seeing a fulsome investment in those changes.
Something interesting happened on my way over here. I was on the ferry this morning, and this ties into it, I promise. And I met this couple that were headed over to Tofino for a birthday. And one of the partners was really on board with harm reduction, and the other absolutely was not, and lives right outside of the downtown east side in Vancouver. And we just got on topic without me even mentioning what my work is or like anything about my background. It came up by virtue of this person mentioning where they lived, and that if they were to turn left out of their home, it's kind of like, you know, fancy stores and restaurants and places to get drinks versus what he referred to as the apocalypse if you were to go the other direction. And a lot of what the conversation centered around was, aren't all, you know, these Band-Aid services just making things worse, right? And we were talking about how it's become more exposed potentially by virtue of the housing crisis, right? Which we can't say is about drug use, right? We know that there's issues of poverty that are framed as drug use issues. And what this person's partner said to them was, a bar is a supervised consumption site. And that's probably something all of us in here have heard many times, right? But to this person on the ferry, it was a light bulb moment. Like, I'm not kidding. Like, and I'd never seen anything like he kind of sat for a moment and then started giggling and was like, I guess it kind of is, right? And we talked about these examples of like how the bartender is, you know, has an obligation around making sure of your welfare and safety within the space. And I kind of returned to something as simple as that because I hadn't seen in a long time somebody be so taken by something that I think that we have like come to see as like really just this simple part, almost like, you know, the meeting people where they're at when it was mentioned in a previous panel about it's something we hear really often, but I don't know if it's always part of the public discourse or narrative. And that's not to say that we're in an echo chamber per se. I think that there's dehumanization that's part of, you know, and stigma as part of this moral panic that leads to people not necessarily having their ears open for what some of these comparisons might be. So I'd love to hear what my other panelists have to say about that too.
One is the enormous power of the status quo. One of the things that I find really difficult to communicate is how profoundly unacceptable the status quo is. And so you try to propose a solution that is out of the realm of what people are used to, and there is all the risks associated with that solution. People don't put that against the risk of the status quo. And so I think one of the powerful things, and again, the two addiction medicine physicians spoke about this, is drawing parallels to things that people are used to is potentially a way of starting to normalize some of these things. Harm reduction is a chronic disease management. I sometimes think about Ventolin or steroids for asthma. Ventolin is harm reduction, steroids is treatment. Nobody's outreached by either. I do think we have one really big issue, though, in the interventions that we have put in place, and I've got a bit of an analogy for it, which is a question of dose. We have a very large issue, 225,000 people, and most of the interventions we've rolled out have occurred in really a pilot sites in very small doses. And I drew this analogy to antibiotics. If you have an infection, you could have the right antibiotic, but if you don't give it in the right dose for the right duration, you won't treat the infection and you'll develop resistance. And I think what we've done societally is that these interventions that in themselves are effective, we have excellent evidence, but we haven't rolled it out at the right dose. So independently of the interventions, due to things like border closures, the overdose crisis got worse, and people associated these small interventions with the worsening of the overdose crisis, to the point that I was in Ontario with my public health colleagues, and they literally had the narrative, well, BC rolled out a safer supply program, and look what happened there. And I thought, okay, so the problem with this, that we didn't roll it out, it's not really safer supply, and it has nothing to do with the trajectory of what happened. So I think we have some really amazing projects, we have some really amazing programs that are serving the people that are able to access those programs. But the notion that we've rolled out in British Columbia a safer supply intervention at the scale of the problem is really, really flawed. And I think we're actually fueling some resistance because people are making false associations.
Yeah, I agree wholeheartedly, Reka. In some of the work we've done, we've shown at a population level, and we do this by looking at administrative data, which gives us information on every person in British Columbia who had access to prescribed alternatives, prescribed safer supply, however you want to name it. And it's well below 10% of the estimated need it's out there, so 10%, less than 10% of folks who are at risk of overdosing were getting these medications. Now, that's actually very interesting to me because throughout my career, I see that statistic for pretty much all treatment services. Any kind of services for substance use at less than 10%. Okay, so we're pretty good at getting about 10%. So what's happening with the rest of the population? When you introduce a service that is a little bit outside of the norm and it, like prescribed safer supply was, and people don't see things getting better right away, same thing happened with decrim, it becomes the scapegoat. And it becomes the scapegoat through the processes that Corey highlighted around moral panic. We were being, at the same time that we were seeing a worsening of a crisis and we're seeing interventions introduced that do help, we see the rhetoric and we see the fear growing and we see, I completely understand the urgency of the situation, the desire for a silver bullet, the desire to see change happening now. And structured research takes time, which is very frustrating. It's frustrating for me, and I'm doing it. However, at the same time, you know, thoughtful research is coming out that is showing this saves lives. Prescribed safer supply saves lives. There are people alive today because they got prescriptions, and it didn't matter. Didn't matter. It's not about evidence. And so one of the conversations I've had with Corey before is, okay, so we know what works, we know what causes this, as Corey very eloquently started us with. We know what works, we know what's causing the problem. We're not really able to get there. I'd like to see a shift away from the kind of research I do, where I'm looking at interventions, to seeing, okay, so how do policy processes work? How does moral panic work? How does media and representation and power operate in society such that the evidence isn't being used? I want to see that. I want to see research that tells us how do we work with people with different types of opinions and help to inform them, because we know that education alone doesn't work. We know that. It doesn't work for the reasons that Corey's already outlined. So how do we go about that? How do we understand how power infiltrates and changes the narrative such that we are now unable to get our research findings incorporated into policy when the outcome is death? We're not talking about different ideas of recovery. We're not talking about what your own quality of life entails for you. We're talking about keeping people alive. And the loss of life isn't enough. And I think we need to talk about why that is. Because for me, that's the foundation. If you find something that is preventing people from dying, that's the foundation. The rest is details. How you do it, how you implement it, who does it, where is it done. That's all details that we worked out. But if you've got the foundation that it saves lives, what else do you need? Why isn't that enough?
In my master's, I'm studying moral panic and misinformation and disinformation and what the policy implications are of a moral panic. And so I could talk about this for a very long time, but I promise I won't. What I will say is that there is one important piece that makes disinformation effective. There's one important factor that makes a moral panic gain traction, and that is that it is usually wrapped in truths. And so there are things that are happening right now that are very distressing. It is not normal to see the amount of people outside suffering in the elements, deprived of housing. It is not normal to see people rendered incapacitated on the streets for hours on end, unresponsive but still breathing because of benzodope in the drug supply. That stuff is scary. And so people are afraid of what they see. You see people driving down Pandora and they might have an angry reaction to seeing visible poverty, but a lot of that anger is rooted in fear. It's fear because we're seeing people in the worst possible conditions in a society that's supposed to have universal access to healthcare, in a society that talks about the right to housing. And so a moral panic is effective when it taps into people's base emotions. And so one thing that I think would be really helpful to kind of part folks with, because I know we're wrapping up for time here, is that we all actually can play a role in combating moral panics. And it doesn't have to be a big one. It could actually be as simple as having a difficult conversation with someone. And knowing that at the root is fear, you can actually understand that just openly defying someone's statement, saying, no, you're wrong, you don't understand, that's not what the evidence tells us, is not effective. And it actually will make people pit in more on their positions, right? Even in the face of insurmountable evidence, they will pit in on that because they feel attacked. And so instead, the next time someone says to you, boy, I drove down Pandora, what a shit show, right? Thanks a lot, Trudeau. Say, it's really scary, isn't it? I'm really worried about the people who are out there. I feel similarly. And then move into, what do we know about this? Bring people along, give them the opportunity to be wrong. Otherwise, they will continue to be wrong, and they'll do so to the detriment of the people that we love and care about. You can combat moral panics by writing a simple letter to the editor and saying, this is misinformation, this is what the evidence actually tells us. When they use a really stigmatizing photo in a news article about harm reduction, email them a copy of some different pictures that they can use next time. There are a lot of little things that we can do that help shift the narrative. I want to say thank you so much to our panelists today. I want to say thank you so much to everybody here for your time and your attention and your thoughtfulness. Thank you to peers for putting on this important session. And everybody who's a service provider out here who's helping, whether it's treatment, recovery, and harm reduction, or a little bit of both, thank you for all the work that you do in the face of such politicized time. It doesn't go unnoticed. Thanks.